Okay, so I'm going to launch the session. It's 1 o'clock Central Time, August the 4th, and I'd like, on behalf of the Neonatal Hemodynamics Research Center, to launch this inaugural Echocardiography Foundations lecture series hosted by the Neonatal Hemodynamics Research Center. For those of you that don't know me, my name is Patrick McNamara. I'm the chair of the Neonatal Hemodynamics Specialty Interest Group at the American Society for Echo and a neonatologist at the University of Iowa in the United States. I'm the co-chair with Hamish Jane for the Neonatal Hemodynamics Research Center. Just by way of background, what is this lecture series meant to be about? What I think we're trying to create is a virtual academic program for trainees. Just like in most perinatal centers, you will have your neo-peri fellowship program where you will have between 6 and 15 trainees or even more in certain programs at any given time who meet on a regular basis to talk about relevant neonatal issues. In the current landscape, particularly in North America, programs that have existing neonatal hemodynamics fellowships have either 1 or 2 trainees who engage either with 1 faculty or in some programs as many as 5 faculties, but there's not a mechanism for individuals to connect around common educational matters with respect to neonatal hemodynamics. So this is a session for trainees, and I know we have some established hemodynamics faculty that are on the call and who are very welcome to listen into these sessions, but I'm making a very dogmatic statement that the interactive component is for fellows or faculty who are actually currently in a formal training program, because we want to direct this to you. We want this to be a session that you feel is yours, that you're able to ask a question, feel comfortable, and so forth. And we hope that this will be a rewarding lecture series. Just by way of reminding everyone, we also have the joint Pan American Hemodynamic Collaborative Center webinars that happen every 2 months, which are really for everyone, not just hemodynamics people, but for non-hemodynamics people. So we hope that people find this as a value. Within our Neonatal Hemodynamics Research Center, the educational working group is led by Danny Weiss from Subcostal in Toronto, who was the lead for the establishment of the AFC diploma program in hemodynamics at the Royal College in Canada that hopefully will be fully approved very soon. And Danielle Rios, who is a neonatology researcher at the University of Iowa hemodynamics faculty here, and they have taken the lead on putting the session together. I've said my words. I'm going to hand it over to Danielle, who is going to open the session, introduce the speaker and the co-panelist for the session. So Danielle, I will hold the reins over to you. I will turn my camera off and hopefully you will be able to use your camera.
Thank you so much, Patrick. And Laura, it's not actually letting me, oh, there we go. Okay. So I want to thank you, Patrick, for the introduction to the entire lecture series. I also want to recognize and thank Danny Wise, who I see is actually on the panelist session at the moment. And the two of us have kind of been working together to put together this lecture series. So we're really hoping that it's an enjoyable experience for not only the hemodynamics trainees, which we hope get the most out of this, but also to other faculty and fellows as well. So I would officially like to welcome all of you to the initial session of the targeted neonatal echocardiography and or neonatal performed echocardiography foundations lecture series. Please think of and write any questions that you come up with while our speaker is presenting into the Q&A area that you can find at the bottom of your screen. We will be going through all of those questions at the end of the presentation. So please, anything you think of, write in there so that we can present them to our panelists. So I do have the distinct pleasure of introducing our inaugural speaker. Jacqueline Wheatley is a pediatric cardiac sonographer and quality leader at the Hospital for Sick Children in Toronto. She is currently part of the cardiovascular ultrasound research team, and in partnership with Mount Sinai and Sunnybrook Hospitals, her focus is on neonatal echocardiographic research analysis. She is also a cardiac sonography skills instructor in the nationally recognized and accredited diagnostic cardiac sonography graduate program at Mohawk College in Hamilton, Ontario. So we are looking forward to a fantastic talk from her about the basics of echocardiography. Jackie, if you want to take over.
Hi there. Thank you very much for the introduction. I'm just going to go ahead and share my screen and hope this all works out for everybody. Okay, assuming that you can see this, I'm going to go ahead and start the presentation.
Hi everyone, welcome to the first lecture of the Targeted Neonatal Echo or Neonatologist Performed Echocardiography Foundation Series. My name is Jacqueline Wheatley. I am a pediatric cardiac sonographer and quality lead at the Echo Lab in the Hospital for Sick Children in Toronto, currently with a focus on neonatal echo research. I will be reviewing foundations of echocardiography. I have no disclosures. For this lecture, we will go over the basics in machine setup and probe presets, image optimization tools. Then we will review the echo imaging protocol, where we'll review basic anatomy and scanning. We'll review how to perform the measurements for this protocol. And as we go through each echo window, we'll discuss a few pitfalls by critiquing some images. Lastly, we'll look at artifacts and other shiny things. Let's start with our machine setup. For the initial setup of the machine, we will want to have the calibration of all of our machines to be the same so that we have a uniform appearance of studies. Beware that there are not only differences that exist between manufacturers, but as the machines have evolved, each model will of course have its own variations as well. So it's very important to get to know the machine that is in your own lab. There are multiple cardiac ultrasound probes available, and we want to choose the right one for your patient's size and anatomy focus. Now, the higher the frequency of the probe, the better the resolution, whereas the lower the frequency of the probe will get better penetration. So the goal is to choose the highest frequency probe that allows adequate penetration. For our neonates, selecting a probe is rather simple. Since we do not need to travel a far distance, we can choose the highest frequency probes. Not only will these S12 probes give us the best resolution images, the footprint or the contact surface of the probe is smallest, which of course fits best for our small babies. Most probes have a range of frequencies within one probe. So let's say we are scanning on that mid-range, or some machines label it general frequency, and feel like we need a little bit more penetration. We can try switching to the lower range of frequencies or penetration setting of your current probe, or if you want more resolution, you can try switching to the higher range of frequencies or resolution setting. For our neonates, we should try to image with the highest frequencies available. Tissue harmonic imaging is a very popular technique in pediatric and especially in adult imaging. It filters the received frequencies to create an image that has both better lateral resolution and improved signal-to-noise ratio, which in larger patients means that the image is more crisp, as we can see here in the examples. However, the processing required for this technique may make structures appear thicker in comparison to the fundamental frequency, which is not very helpful in small hearts. So in neonatal imaging, it is actually recommended to use the fundamental frequency. In neonatal imaging, we flip some of the images so that the near field is at the bottom of the screen. We invert some images to give us a more anatomical orientation as compared with the traditional adult orientation. And we do this simply by clicking the up-down invert button. At the same time, be careful to never click the left-right invert button. It will confuse the anatomy. The image on the right here has been left-right inverted, and it has placed the pulmonary artery on the wrong side of the aorta. So pay attention to your probe's indicator. The mark on the probe should match the mark on the image. It is very important for orientation, especially when there is complex anatomy. The last item about setup are the presets. You can choose one of the factory presets that have specific settings for adults or pediatrics, and some even have specialties like coronary arteries that are set up specifically to help you show the small vessels. You can also create your own preset. Ultrasound machines have improved significantly, and the factory preset for neonatal imaging is excellent and is what we use at our institution day to day. If you do need to create your own, you should follow the main principles of setting the probe to the highest range of frequencies available and starting with the fundamental frequencies. There are other settings that you can preset, but I want to stress how important it is to learn how to adjust these individually as you image different anatomy. This takes me to the next section of our talk, image optimization. There are two primary challenges in imaging neonatal hearts. With the small size of their hearts, we need to focus on spatial resolution, or how well we can define cardiac structures. Secondly, the fast heart rates of the neonates puts our attention on temporal resolution, or how fast we track cardiac movement over time. If we have too slow of a frame rate, we might miss something. Lucky for us, the new neonatal probes have quite good frame rates, but we still should be aware of the image settings that could degrade our temporal resolution. So let's look at what tools we have to do this. Knobology is referring to the function and use of all of the buttons and dials and touchscreen options that we have to optimize our echo images. Echo machines have all of these scanning modes that each have its own set of controls. Then there are other controls that allow us to complete the rest of the echo study, and there are many more than what I've listed. For this lecture, we'll focus on the basic scanning modes and the most common controls that are routinely used for optimization. I want to note that the volunteer I scanned to demonstrate the following optimization tools was a very cooperative 2.5-year-old using an S8 pediatric probe. So the frame rates and distances I mentioned will be specific to this child, but of course the theories apply for all probes, and these optimization tools should be used in our neonatal studies. The first step I take in 2D imaging is depth, which adjusts how deep we want to image. It influences the frame rate, where the longer the ultrasound transmit distance, the slower the frame rate. This image has a depth of 15 centimeters with a frame rate of 46 Hertz. If your aim is parasternal long axis, there's a lot of unused space below the heart. So I've decreased the depth in this image to 6 centimeters, where we can now fill the screen with the heart, including the pericardium. Notice that the frame rate has improved to 95 Hertz. This would be an appropriate depth for this parasternal long axis because the region of interest is filling the sector. Next is width. It changes how wide or narrow your sector is. It also influences frame rate because it changes the number of scan lines that are needed to create the image. This image has the max width of the sector with the frame rate of around 51 Hertz. But if we wanted to focus on the mitral valve, we can narrow the sector to cover just the mitral valve. And here we've got the frame rate of 117. So the optimal width is dependent on what the region of interest is. The focal zone is where you will get your best lateral resolution. With the image on the left, the focus is placed here in the near field. On the image on the right, I have moved the focus to the level of the mitral valve without altering any other settings. You can see that there's already a brightness improvement to the image and that the mitral valve is seen a little bit more clearly. So the ideal location for the focus is at the region of interest. The gain setting is the brightness of the whole image. It adjusts the amplitude of all signals that are received. The image on the left has a gain setting of about 97%, which is much too high, where the heart is not only too bright, but there's also a lot of background noise in the blood pool. To find the right amount, we can decrease the overall gain until you see a minimal amount of speckling in the blood pool, and then decrease it just one more step so that the speckling is gone. And here we have a gain of 57%. So the overall gain is optimal at the level just before random background noise is seen. TGCs and LGCs stands for time gain compensation and lateral gain compensation, which adjusts the brightness at individual levels. TGCs adjust gains at specific depths, whereas LGCs adjust gains at specific columns. Here, the TGC sliders have been increased in the near field, and we can see the brightness at the top of the image. In this image, the lateral gains have been increased on the left side of the sector. The goal is to have an image that is even and uniform, and adjusting the gains at different levels can help. Compression is the amount of contrast. Do you want more levels of gray, or do you want the images to be more black and white? It is important to not over-compress so you don't lose information on your image. In these images on the IE33 system, the first image has a compression setting of 60, which means that it has many levels of gray, especially compared to this image that I think has too few levels of gray, set at 37. So we'll want something in the middle. The optimal amount of contrast depends on your preference. I personally prefer more contrasted images, but again, you'll want to make sure that you are not over compressing and lose details like texture. The default setting on the GE E95 is 63, and I would not go any lower than 60. The last technique I want to mention about 2D images is zooming. As it implies, it enlarges an area of interest and is helpful when assessing valves, clots, or other small structures. So we have our larger image of the peristernal long axis, but we want to investigate the mitral valve in more detail. Using our right zoom, we can select the area of interest and activate it. Since this method only scans the selected section, you get better resolution and the added bonus of a higher frame rate. Now, this is different from read zoom, which simply magnifies your original image, so you will not gain a higher frame rate or better resolution. Moving into color Doppler, when we've activated the color mode, we will of course move the color box to the blood flow that we are assessing. Adjusting the size of the box is important because increasing the width will require more scan lines per frame, and this will slow down your frame rate just like in 2D. In this image, with a color box of this size, the frame rate has already been reduced to 30 Hertz. But if the color box is increased to the width of this image, the resulting frame rate is only 10 Hertz, which is very poor temporal resolution. So optimally, we'll have our color box covering only the region of interest. The same thought applies to the depth of our color box, since again, a longer transmit time will slow your frame rate. For example, in this peristernal long axis, with the color box over the aortic valve, we get a frame rate of 37 Hertz. But when we move it deeper to cover the mitral valve, we get a frame rate of 21 Hertz. In order to increase the frame rate, but still have the color box covering the deeper mitral valve, we can use our previous tricks like narrowing the color box or the entire 2D sector. The color Doppler scale is the setting that allows us to change which range of velocities we want to display. So it's also called a velocity range or a Nyquist limit. Since there are different blood velocities within the heart, it is important to change it according to the flow being profiled. For example, let's look at these right pulmonary veins. With a scale of 50 centimeters, we can clearly see the right upper, right lower, and even the right middle pulmonary vein. If we increase the scale to 82 centimeters per second, we can still see the right upper pulmonary vein, but now we've lost the right lower pulmonary vein because the scale is too high. So to contrast this, if we decrease the scale to 15 centimeters per second, there are so many low flow velocities shown that it's hard to even pick out which pulmonary veins are there. So the optimal scale for imaging these pulmonary veins is around 50 centimeters per second. I've listed here the suggested optimal velocities for these other types of flows, but they are a guideline only. It's important to set lab standards for color scale so that your color jets are comparable in future studies. It is also important to note that you may need to adjust the color scale in certain hemodynamic situations. The adjustment for the gain setting in color Doppler is similar to the guideline for 2D gain. Looking again at the right pulmonary veins, the color gain is set only at 55%, and here we can hardly see the flow from the pulmonary veins. If we increase the gain all the way to 95%, there is color everywhere, including the speckling noise in the background. So our rule is the same as 2D, where it is optimal at the level just before speckling is seen. The right amount of color gain is important not only because we want to see the flow data, but because an incorrect setting can lead to misinterpretation. For example, if we are looking for the amount of regurgitation, if our gain is too low, we can underestimate the severity. Moving on to spectral Doppler, there are two modes that we will use. In pulsed wave, we are able to sample a specific location along the ultrasound beam, but we are limited to an upper velocity limit. In continuous wave, we are sampling along the entire length of the beam, so we cannot tell where we are getting our velocities from, but there is no upper limit. In either mode, we will need to optimize the spectral Doppler tracing. Like in color Doppler, the scale adjusts the velocity range we want to display, and we will optimize it for the flow we are interrogating. Here the scale is too small, which results in aliasing, or when the velocity exceeds the scale and wraps around. So we can increase the range to allow us to see the whole flow pattern so we can measure it correctly. We can also shift the baseline to allow for maximum use of the tracing. The baseline here has not been changed, and we can see that the flow is wrapping around. So we can shift the baseline up, and now we can see the entire flow pattern and again be able to measure it correctly. Wall filters can eliminate the low frequency echoes like noise and remove the clutter around the baseline. But be careful, because when there is a high filter, we can be missing low velocity flows that may be important. With a low wall filter, we can include the low velocity flows and see the Doppler profile reaching the baseline. Gain for spectral Doppler has the same rules as 2D and color modes, where we want to go just to the level before the speckles appear in the background. With too little gain, we will not show the entire flow pattern, and with too much gain, we can over-exaggerate the borders of the flow pattern, and that can cause us to overestimate the gradient. The sweep speed adjusts the number of cardiac cycles that we display on our tracing. Usually we want 3 to 5 cardiac cycles for comparison and to make accurate measurements. This tracing was set at 100 millimeters per second at a heart rate of 125 beats per minute. But we may want to decrease our sweep speed if we are assessing for a respiratory variation. Patients with arrhythmias may also require some adjustments, like decreasing sweep speed or taking multiple traces to allow for accurate assessment. When using Doppler, it is important to have the most optimal angle. Ideally, we want to be parallel to the flow we are interrogating, or as close to parallel as possible. This tracing of the abdominal aorta is fairly close to parallel, whereas this tracing has a poor angle. Here, the abdominal aorta we are sampling is almost perpendicular. We can see how different these patterns are, and if we have a poor Doppler angle, we can severely underestimate the velocity. When using pulse wave Doppler, not only is it important to have a good angle, it is also important to be specific about where we place our sample volume. For example, if we are assessing diastolic function and we want to pulse the mitral inflow, we would want to place our sample volume here at the tips of the leaflets to get a proper tracing. But if we place the sample volume just a bit far into the LA or a bit too far into the LV, the corresponding tracings will, of course, not be the same. So be sure to place the sample volume correctly in the flow you are interrogating. I want to mention M mode and the importance of alignment. We want to take care to align the cursor properly to our region of interest. For this parasternal short axis, we want the cursor to be perpendicular to the ventricular septum and cutting through the middle of the ventricle. It is critical that the cursor or the probe is not cutting the ventricle obliquely, so that the M mode tracing is correctly representing chamber and wall dimensions and not over or underestimating. For the last item for optimization, I want to mention the importance of patient comfort. Of course, keeping our sensitive neonates stable and settled is crucial for patient care, but setting them up comfortably will also help our imaging. We want to ensure the baby is settled and wrapped securely, but comfortably, before the beginning of the exam. We can always ask the bedside nurse for assistance in adjusting tubing or positioning. Ideally, do not add any additional ECG stickers. Instead, use the auxiliary cable to plug into their monitor. Always use a sterile gel packet for each baby to minimize infection risk. We can remove the outer packaging and place a sterile gel packet inside the isolette to warm up while we do our machine setup. The warm gel will be less of a shock to the baby. Not much pressure is needed for neonatal echo. We can gently place the probe on top of the skin to acquire our images. And we can always ask the bedside nurse to monitor the baby throughout the exam to ensure that they are tolerating the exam well. The next section of this lecture will cover the T and echo protocol. I'll review the images and measurements that are required for each echocardiographic window, and we'll discuss a few pitfalls by critiquing some images. And we'll start with the apical window. When placing our probe for the apical window, we ensure that we are imaging from the true apex. Start low on the left ribs and slide up until you can see the apex. Using this method can ensure that we are not foreshortening the ventricles. This window is also up-down inverted. We will start our study with focus on the left ventricle. With the probe indicator at around 3 o'clock, we image the reference apical 4-chamber view. Both sides of the heart are seen in this view, but since we will image the right side separately, here we want to optimize the left ventricle, the mitral valve, and the left atrium. Importantly, we want to enhance the endocardial border definitions of the ventricular septum and the lateral wall. We want to avoid artifacts and foreshortening of the LV and ensure that the sector is wide enough to cover the whole heart, including the epicardium. For the apical 2-chamber view, we'll rotate the probe counterclockwise to about 1 o'clock, or until the RV is no longer visible. Again, focus is on endocardial definition and to avoid foreshortening, so we can clearly define the inferior and anterior left ventricular walls. We can use the left atrial appendage to help orient us, as it is an anterior structure. Note that the apex is not foreshortened or rounded, and we can follow the apical endocardium. For the apical 3-chamber, we continue to rotate counterclockwise to around 10 to 11 o'clock. Again, endocardial definition is key, but we will also want to see both the aortic valve and the mitral valves clearly. Please note that this 3-chamber has the apex slightly cut off, so this segment would not be included in strain analysis. To optimize this image, we can slide the apex to the center of the imaging sector, or we can widen the sector width. Using the optimized 4 and 2-chamber views, we will calculate an ejection fraction using Simpsons biplane method. First, we freeze our 4-chamber image at end diastole when the mitral valve closes. Using the machine's measurement package, we click the hinge point of the mitral valve and trace along the endocardial surface to the apex. We do not include these trabeculations in the volume as we trace along the lateral wall, and click again at the lateral mitral valve hinge point. The machine will automatically close our volume with a line connecting our 2 hinge points. We scroll along the cardiac cycle until the end systolic frame, where the ventricle appears smallest, and we repeat the process. False chords and papillary muscles are never included in the volume, making it crucial to be able to visualize the endocardial surface. Once we have both end diastole and end systole traced, we repeat the process for the 2-chamber view, and we can report our Simpsons EF. I'll take a pause here for a quick image critique. This apical 2-chamber view has a clear mitral valve and LA. However, notice the apex. It appears to collapse into the ventricle. This 2-chamber is foreshortened and cutting the LV obliquely. When we freeze the end systolic frame, notice how there is a rounded appearance to the apex, and we've lost the true length of the ventricle. So this will not be usable for Simpsons biplane. It can be difficult to define the endocardium, and it is important to avoid mistaking other anatomical features as the endocardial surface. In this 2-chamber view, we see a papillary muscle as well as some false cords or tendons. When tracing, be sure to include these within the volume trace and not mistake them as the endocardial border. The three apical views of the LV will also be used to calculate global longitudinal strain and strain rates. I will touch on the methods when we get into the right ventricle. In our apical floor chamber, we will color our mitral valve to look for any regurgitation. Here we can see a trivial amount at the point of leaflet coaptation. This color flow also helps to align our cursor for diastolic assessment. We'll first place our sample volume at the tips of the leaflets, and activating pulse wave Doppler, we can get a tracing of the mitral valve inflow. We'll measure the E wave, the deceleration time, and the mitral A wave. By angling a little anteriorly in the four-chamber view, we can start to open up the left outflow. For isovolumic relaxation time, we align our cursor between the red inflow and the blue outflow, and place our sample volume between the mitral and aortic valves. Activating pulse Doppler, we get our tracing and can measure the time between the aortic valve click to the beginning of the mitral inflow. For pulmonary vein Doppler, we align the cursor with the right upper pulmonary vein color flow and place the sample volume just inside the pulmonary vein. Decreasing the color scale will help to enhance the flow. After activating pulse Doppler, we can measure the systolic, diastolic, and A-wave reversal velocities. Having a clear, large ECG tracing is very beneficial in all images, as it can be used to help guide your measurements. Returning to four-chamber view, we can activate colored tissue Doppler and align our cursor to the septum. We'll place our sample volume in the basal segment of the ventricular wall and ensure that it does not cross into the atria as the heart contracts. On the pulse Doppler tracing, we can measure the E prime, the A prime, and S prime velocities. We repeat this for the lateral LV wall as well and perform timing measurements, which we'll cover later on. For the apical 5-chamber view, we angle anteriorly from the 4-chamber view. It is important to be able to clearly visualize the aortic valve and the left ventricular outflow tract. Left ventricular output, or LVO, requires two separate measurements. From the apical 5-chamber view, we'll use our colored Doppler to help align our cursor to the outflow. We sample the LVOT just proximal to the aortic valve. With pulse wave Doppler, we'll trace along the systolic flow profile from baseline to baseline. The first heart rate marker is automatic based on where we started our trace, so the final step is to drag the cursor along the ECG to the beginning of the next systolic waveform. Now we have the relevant parameters for the first part of the LVO calculation. We'll move now to assessment of the right ventricle. By sliding or tilting slightly, we can align the 4-chamber view to focus on the right atrium, the right ventricle, and the tricuspid valve. We aim for parallel alignment with the tricuspid inflow and visualization of the RV free wall, which is more difficult to accomplish when we have the image aligned for the left ventricle. Again, we try to avoid foreshortening, and have a wide sector width is beneficial to include all anatomy. When we add color flow over the tricuspid valve, we can assess for regurgitation. Then we line up the cursor to the red inflow and place our sample volume at the tips of the tricuspid leaflets. Then activate pulse Doppler to measure tricuspid valve E and A waves. It is typical to see the E and A waves fused because of fast heart rates. For the measurement of TAPSE, we want to optimize our image so that the RV free wall is parallel to the cursor. Once aligned, we activate M mode. This can be done with or without color tissue Doppler. First, we mark the highest annular position and draw a line towards the lowest point of annular movement. The distance between these two is our tricuspid annular plane systolic excursion. While we have our optimal alignment for the RV free wall, we can acquire tissue Doppler velocities. We'll place that sample volume in the basal segment of the free wall and capture the velocities here. Notice the variations between the cardiac cycles. Averaging 3 cycles on the right side will minimize the amount of variation reported. Changing the sweep speed, we can spread a single cardiac cycle to better perform timing measurements for our tissue Doppler. It is very important to have a clean tracing for accuracy. We start by measuring the IVCT, or isovolumic contraction time, then measure the right ventricular ejection time, followed by the IVRT, or isovolumic relaxation time. Next, we measure the right ventricular filling time, and finally, the time from closure to opening of the tricuspid valve. Timing measurements are the same for the LV lateral wall, except that we typically do not measure IVCT. For right ventricular dimensions, we freeze the end diastolic frame with the tricuspid valve closed. The basal diameter starts at the basal bulge and runs to the septum. We aim to stay parallel to the line that is created by the tricuspid valve hinge points. We measure the RV length starting from this line to the RV apex. To calculate fractional area change, we measure RV areas. Using that same end diastolic frame, we can measure the end diastolic area. We begin by selecting the lateral tricuspid valve hinge point and trace along the endocardial surface of the RV free wall. This is one of the most difficult traces to do because it is often difficult to differentiate between the trabeculations and the true endocardium. As we continue the trace up along the septum, we have to be careful to not trace the trabeculations. Selecting the septal tricuspid valve hinge point will close the area with a line between the hinge points. We scroll along the cardiac cycle until the end systolic frame, where the ventricle appears the smallest. To get the end systolic area, we will repeat the process. As we trace along, we again do not include any trabeculations or the moderator band or any of the tricuspid valve apparatus. It often takes several times of scrolling between the end diastolic frame and the end systolic frame so that we can follow where the wall travels to. This scrolling between the frames helps to correctly identify the true endocardium. To perform longitudinal strain for the RV4 chamber, we first need to select an image and then a specific cardiac cycle where the RV free wall is clearly seen with a strong and clear ECG. Though this image is likely an LV-focused 4-chamber, it has excellent visualization of the RV free wall, from endocardium to epicardium, from apex to beyond the tricuspid valve. The image chosen should be free from artifacts and not foreshortened. Using the software package, we draw calipers along the endocardial border, similar to the area tracing. We assess how well the speckles track throughout the cardiac cycle, and once we feel confident with the speckle tracking, we approve the tracking and can analyze results for peak global strain and systolic strain and strain rates. Notice that there are only 3 strain curves here. Some institutions use the average of all 6 segments, including the septal segments, in their global RV strain. However, we have chosen to exclude the septum. It is important to be consistent with the methodology in your own lab. In this RV4 chamber view, we see a bright artifact covering the basal segment of the RV free wall. When we attempt speckle tracking, we see that the red basal segment attempts to track this artifact and not the true basal wall. Notice that the annulus moves past the tracked area. In this case, we would exclude this segment from our average strain. We will exclude any segments that do not track well, but in order to report a strain average from any one view, at least 2 of the 3 RV segments must track well. If only one segment tracks well, we cannot use this as an average strain. For the left ventricle, at least 4 of 6 segments must track well in each of the LV apical views in order to report the LV global longitudinal strain. Here is our next image critique. In this RV4 chamber, we have very nice alignment of the tricuspid inflow and good visualization of the RV free wall. Unfortunately, the aortic valve is seen, so the angle of this probe is too anterior. This RV4 chamber will be difficult to compare with other 4 chambers for this baby, since the RV4 chambers should be at the level of the mitral valve and not the aortic valve. Comparing another RV4 chamber view, here we have some dropout of the RV free wall, or simply too little overall gain. There's not enough image here to trace the endocardial walls. Additionally, when we freeze the end systolic frame, the apex is out of the frame, so we would not be able to complete either the length and area, nor include these segments for strain. We can adjust this by making the sector slightly wider. To achieve the RV3 chamber view, we can start from the 2-chamber view of the left ventricle and angle anteriorly to the RV. We then rotate the probe slightly until both the tricuspid and the pulmonary valves are well seen and opening maximally. Our focus is on endocardial definition of the RV wall, and as always, we try to avoid artifacts and foreshortening. We'll repeat our RV areas to calculate fractional area change in the RV3 chamber view. Freezing the end diastolic frame with both valves closed, we can measure the end diastolic area. We begin by selecting the lateral tricuspid valve hinge point and trace along the endocardial surface of the RV wall. We'll avoid the trabeculations and tricuspid valve apparatus and follow the endocardial surface up towards the pulmonary valve. We trace a straight line across the pulmonary valve from hinge point to hinge point and trace along the aorta. And again, we'll draw a straight line across the tricuspid valve hinge points to close the area. We'll then scroll along the cardiac cycle until the end systolic frame, where the ventricle appears smallest, to get the end systolic area. We will repeat the process. As we trace along, we again do not include any trabeculations. We can again use a method of scrolling between end diastolic frame and end systolic frames so that we can follow where the ball travels to ensure that we are tracing the endocardial border. Be sure to avoid tracing any muscle around the aorta. Let's critique these RV three chambers. The image on the left is a decent three chamber with both tricuspid valve and pulmonary valve seen, and some good endocardial definition on the tricuspid side. Unfortunately, we have a bright artifact which reverberates across the outlet portion of the RV wall. We could try sliding our probe slightly, but these bright artifacts are quite common in our neonates. The image on the right is foreshortened. Notice that we cannot see the cavity of the right ventricle nor the tricuspid valve, as well as the image on the left. The probe has slid too far up the chest and is close to a peristernal window. So to fix this image, we can slide back down towards the apex. Using the RV3 chamber, we will also complete strain analysis to calculate peak and end systolic strain, as well as strain rates. In every image where we see the tricuspid valve, we will always attempt to estimate RV systolic pressure. We do this by measuring the tricuspid regurgitation jet. We attempt it in every tricuspid valve view because we are aiming to measure the highest TR jet. For this patient, their TR jet was best aligned in the RV3 chamber, so we place the cursor parallel to the regurgitant jet and activate continuous wave Doppler and measure the peak. It is important to measure TR only when there is a full flow profile. Since most trivial jets will only produce this type of tracing, we cannot measure this spike as true TR velocity. Moving into the peristernal window, we'll start in the long axis. Our probe indicator will point towards the baby's right shoulder for long axis. In the peristernal long axis reference image, we assess the aortic valve, the mitral valve, the left atrium, and left ventricle. We want to ensure clear endocardial definition of the ventricular septum and posterior walls, since ventricular dimensions can be measured here. We'll color both the aortic and the mitral valves to assess for regurgitation. When I am imaging valves in color, I always do a small sweep of the valve to rule out any eccentric jets. The second measurement needed for left ventricular output is the left ventricular outflow tract diameter. We'll zoom into the aortic valve and the LVOT and freeze the image. We'll select the end systolic frame just before the aortic valve closes, and we'll measure the LVOT just proximal to the aortic valve annulus. This is the same location that we sampled earlier in the 5-chamber view for the LVOT VTI. Note that the LVOT diameter is parallel to the plane of the aortic valve annulus. Now that we have both measurements needed, we can calculate the LV output. Lucky for us, the machine automatically does this. From the peristernal long axis, we angle inferiorly towards the patient's right hip to attain the right ventricular inflow view. Here we can assess the right atrium, the right ventricle, and tricuspid valve. We want to angle far enough so that the LV is no longer in view. This is important because this view is the only one where we see the posterior leaflet of the tricuspid valve. Most of our other tricuspid valve views are of the anterior and septal leaflet. We'll also ensure that our sector is wide enough to image the entire anterior wall and leaflet. Looking at this RV inflow view, we see that the probe has not angled far enough, and now we can see the left ventricle and the ventricular septum. This leaflet here is likely the septal leaflet, and the sector width is also quite narrow, so we cannot visualize the entire anterior wall. From the inflow view, we angle superiorly towards the baby's left shoulder to open the outflow view to image the right ventricular outflow tract, the pulmonary valve, and the main pulmonary artery. Similar to LV output, we get RV output by providing two measurements. For RVOT diameter, we again freeze the end systolic frame right before the valve closes. For RV output purposes, we measure the pulmonary annulus as our RVOT diameter. This will allow the machine to perform the calculation. Exactly like LV output, we trace the RVOT VTI and the heart rate, but note that the sample volume is at the pulmonary valve, the same spot we just measured the diameter. Now we have both measurements we need for RV output. For RV ejection time and pulmonary artery acceleration time, we place the sample volume just below the pulmonary valve. The RVET is measured between the beginning of the systolic waveform to the end of the waveform. and pulmonary acceleration is measured from the beginning of the RVET to peak velocity. We will acquire these two pulse wave tracings, both at the pulmonary valve and below the pulmonary valve, in each of the three windows that we image the pulmonary valve, in the RV3 chamber, the peristernal long axis, and short axis. Then we can choose the best tracings, the ones with the strongest signals and cleanest waveforms, to perform the measurements. In this pulse Doppler below the pulmonary valve, we see the turbulent flow of a patent ductus arteriosus. In this instance, we cannot measure the pulmonary acceleration or the right ventricular ejection time. Another use for the pulse Doppler trace below the pulmonary valve is to assess for mid-systolic notching. These are two examples of this indentation in the middle of the systolic flow pattern, creating biphasic flow. Compare that to the monophasic flow in this image without notching. We'll next move into the short axis of the peristernal window. From the long axis, we'll rotate our probe 90 degrees so that our probe indicator is pointing towards the baby's left shoulder. The first short axis level is at the aortic valve. We want to clearly define all three cusps of the aortic valve. For the pulmonary and tricuspid valves, we may need to reposition our probe slightly to fully open the valve leaflets. We can see that this tricuspid valve here is not well seen. We can also assess the left and the right atria and the atrial septum. This view may be helpful to rule out atrial shunting if subcostal views are unavailable. We'll also color all valves to assess for regurgitation. Angling below the aortic valve, we can assess the mitral valve leaflets. This view can help to ensure that we have the correct short axis rotation. If we cannot see both points at which the anterior and posterior leaflets come together, then we are likely under or over rotated. Now that we have checked for proper short axis rotation, we can angle further into the left ventricle and acquire images for the basal level, which is just below the mitral valve level, the mid-ventricular level, which is at the level of the papillary muscles and should not have any mitral cords, and the apical level, which is beyond the mid-level, where there should not be any papillary muscles seen. It is important to ensure that we are scanning perpendicular to the ventricular septum so that we can properly assess septal curvature and wall motion. Using optimal short axis images, we can assess septal curvature. The baby at the top has maintained septal curvature throughout the cardiac cycle, whereas the baby on the bottom has a flattened ventricular septum in both systole and diastole, which indicates elevated pulmonary pressures. For LV dimensions, we will acquire an M-mode trace from either the long or short axis. In the long axis, we'll place the cursor at the tips of the mitral valve leaflets while ensuring that the cursor is perpendicular to the ventricular septum and posterior wall. In the short axis, we'll ensure we have our optimized basal level image, ideally with the right ventricle in the center of the sector, and place the cursor through the center of the left ventricle. Activating M mode will look for clean endocardial lines that can be seen throughout the cardiac cycle. Our LV measurements start in end diastole, where the ventricle is largest. We begin the sequence measurements at the anterior septal border to the posterior septal border, which is the septal dimension. Be careful not to include the RV wall into the septal measurement. The next caliper is between the posterior LV cavity and the posterior wall, which is the LV internal dimension in diastole. We then select the border between the posterior wall and the pericardium for the posterior wall dimension. Next, we move to end systole. Being careful not to mistake the mitral cords, we measure the LV internal dimension in systole and the posterior wall in systole. The LV dimensions will be used to calculate the ejection fraction and fractional shortening. Next is the high peristernal window. From the peristernal window, we'll slide up a couple of rib spaces. With the indicator pointing around 3 o'clock, we can image the right and left pulmonary arteries. Freezing a frame in mid-systole, we can measure the pulmonary artery dimensions. Putting color Doppler over the branch PAs, we can assess the flow as well as align our cursor to pulse the right and then pulse the left pulmonary arteries. Note the red flow in this image of a patent duct. Just anterior to the branch PAs, we have the crab view of the pulmonary veins. Though we do not routinely image all four, we will for first-time studies as well as for babies with pulmonary hypertension. When pulsing each vein, be careful not to mix them up with the superior vena cava and the left atrial appendage. We'll then rotate our probe so that the indicator is around 1 o'clock for the ductal cut. In color compare mode, we can assess the region of the ductus between the left pulmonary artery and the descending aorta. We then perform a slow and methodical color sweep from the baby's right to left. Near the end of this sweep, we see a bright ductal occluder. We color sweep not only to rule out the presence of a PDA, but also to look for residual shunting after intervention. If we do find a PDA, we interrogate further. First, we image the duct in its long axis. This can become very difficult if the duct is tortuous or very small. In those cases, further color compare sweeps are very helpful. We'll freeze a frame at the time of peak shunting, where we can clearly see the borders of the duct. We measure it at its narrowest point. We then place our sample volume in the narrowest section and obtain a pulse Doppler trace. A clean tracing is very important because it can pick up brief points of right to left shunting that can be missed when looking just at the color image, especially when the heart rates are very fast. We'll also take a continuous wave trace for peak and mean gradients. Then we'll slide the probe a little higher into the suprasternal notch of the baby. Ideally, we should extend the baby's head for the suprasternal window, and a small towel roll can help, but please be very careful with the baby's tubing in the isolettes. We should always ask the bedside nurse for assistance. With the indicator around 12 o'clock, we image the long axis of the aortic arch. We aim to open up the ascending aorta and the isthmus arch at the same time. In this image, we can also see the left subclavian artery and the left common carotid. With color flow, we rule out any obstructions and confirm with continuous wave Doppler through the isthmus. Next is the subcostal window. We move our probe down to the belly, just underneath the ribs. Since we need to aim our ultrasound beam up towards the heart, be extra cautious with the amount of pressure used here to obtain that imaging plane. Starting with the probe indicator around 3 o'clock, we perform a long axis sweep from posterior to anterior. This sweep can be used to rule out pericardial effusion or congenital heart disease. Adding a small color Doppler box with a lower color scale can help to rule out atrial shunting. To break down this long axis sweep, we'll start posteriorly at the atrial septum. As we sweep anteriorly, we see the 4-chamber view with both atria, ventricles, and atrioventricular valves. And moving more anteriorly, we see the left outflow tract and aortic valve. Rotating the probe to around 5 o'clock, we will do a short axis sweep from the baby's right to left. Again, the sweep can be used to rule out pericardial effusions and assess cardiac anatomy. With the narrow color box over the middle of the sweep, we can rule out both atrial and ventricular shunts. It is very important to lower the color scale since shunting can be both low in velocity and may not be parallel to the ultrasound beam in this view. To assess or rule out ventricular septal defects, we would also want to image and sweep for them in the peristernal and apical windows. Breaking down the short axis sweep, we'll start rightward, again at the level of the atria. And as we sweep leftward on the baby, we pass through the right ventricular outflow tract, then the mid-left ventricle, and finally out through the LV apex. If we found an atrial shunt in our color sweeps, we can assess it from any angle where it is best seen. We can image the atrial septum in long or short axis, or even something in between. Using color compare, this PFO was best seen in the short axis view. Here we see the right atrium, the left atrium, and the patent foramen ovale in between. We'll freeze the image where the defect can be seen clearly, and we'll measure it at its largest. Finally, we will acquire a pulse Doppler trace. Often it is easy to spot the red left to right shunt, but it is sometimes more difficult to pick up brief right to left shunts. So I slowly scroll through the color image to rule out any bidirectional shunting. When we slow this loop down, we can see a brief shunt of blue right to left flow through the PFO. This would be easier to spot as well with a lower color scale. Let's critique these images. This is a very nice image of the atrial septum with a good sized color box. No obvious shunting is seen. The scanner also acquires a beautiful color compare sweep of the atrial septum. It's smooth, methodical, and really attempts to image the entire septum. Again, no obvious shunting. However, in the peristernal RV inflow view, with the color box intended to show the tricuspid inflow, we catch an atrial shunt. But why did we not see this in the subcostal views? It is likely that this shunt was not parallel to the beam in subcostals. Notice the slight bulging of the atrial septum in that first image. And with the color scale this high, around 70, it was not well seen. This case highlights how important it is to lower the color scale for shunts, since slight angle changes can cause us to not pick these up. A lower color scale is also important when there are high right-sided pressures. Rotating our probe a little more to a 6 o'clock position allows us to fully open the superior vena cava. In this image, we can see the to and fro flow into the right atrial appendage, and here we are catching the turbulent flow of a patent duct in the pulmonary artery. We will pulse the SVC to assess the flow pattern and flow velocities. Inverting our image back to where the near field is at the top of the screen, we'll rotate our probe to around 12 o'clock to image the inferior vena cava. We assess the collapsibility of the IVC, and together with the hepatic vein, we can assess the flow to the right atrium. With color Doppler, we can also align the cursor to sample the hepatic vein. With the probe indicator still at 12 o'clock, we angle leftward on the baby to image the abdominal aorta. We pulse the aorta, but we need to make sure that the wall filter is low so that we can pick up any flow reversal, which is common with large ducts. It is often difficult to align the abdominal aorta with the ultrasound beam in very small babies. Notice how this aorta is nearly perpendicular. So we also look at a few other vessels to assess for flow reversal. First, we pulse the celiac artery and then the superior mesenteric artery. Both are coming off of the abdominal aorta and are usually at a good angle for Doppler. On the left, we have normal flow in the celiac artery, and on the right, there is some diastolic flow reversal seen in the presence of a large PDA. Lastly, we will assess one cerebral vessel in our echo study. We assess the middle cerebral artery by imaging in the transtemporal window. We place the probe at the temple of the baby, and with this imaging plane, the MCA is nearly parallel to the ultrasound beam. We will sample this artery, and again, we'll ensure a low wall filter to look for diastolic flow reversal. Those are the images and measurements of the TN echo protocol. However, if the study was a first echocardiogram for the baby, we would need to complete a full anatomical scan, including arch and abdominal situs, pulmonary venous and coronary connections, as well as ruling out a left superior vena cava and ruling out all shunts. For the last section of this lecture, we'll review some examples of bright echo reflections that we commonly see and discuss whether they are real or not. Artifacts are errors in image production and are normally caused by physical processes that affect the ultrasound beam. Recognizing imaging artifacts is of great importance to prevent misinterpretation of echocardiograms. We care about artifacts because we want to accurately diagnose our patients, and we can only do that if we can tell the difference between what is real and what is an ultrasound artifact. Generally, artifacts will shift when we change our imaging window or change our settings, whereas real anatomical anomalies will be constant and seen in multiple windows. Let's take a look at a few examples. In this 3-chamber view of the left ventricle, we see movement in the far field beyond the heart. It appears to be moving in time with the mitral valve. Is there a second heart hiding beyond the first? Fortunately not. This very bright pericardium acts as a strong reflector, strong enough to mirror the true heart and cause a duplication of the image deep to the reflector. Mirroring artifacts are always equidistanced to the true anatomy on the other side of the reflector. At first glance of this descending aorta, the isthmus region may seem narrowed or crowded. However, there is this significant reflector along the posterior wall of the aorta that is creating artifacts within the vessel. When we apply the color Doppler box, we see the vessel fills quite nicely. There is an additional reverberation here that hides the rest of the aorta, including any color. In this subcostal image, we see the baby's spinal column, and below each vertebrae are areas without any signal. This acoustic shadowing artifact occurs because the transmitted sound waves have encountered the highly reflective bone and no sound waves are penetrating through. This becomes a problem when we are assessing structures within the shadowed space. Like in this example of a color compare image of the aortic arch where shadowing blocks the color flow of the descending aorta. An example of how artifacts can affect strain analysis is this LV 3-chamber. The purple apical segment is not checking the myocardium, but the bright linear artifact instead. Meanwhile, artifacts from the lung cover much of the green apical segment, so despite the software showing us movement of these walls, we cannot trust the measured values because of these artifacts. In the subcostal superior vena cava view, we see some bright spots in the SVC. They could be reverberations or something more, so we need to assess this from a different angle. When we sweep this SVC in the peristernal window, indeed, there is a thrombus on the catheter line right here. For all our babies, we need to assess any lines for possible thrombus. Speaking of lines, here we have a line in the inferior vena cava. Note the line's location in the right atrium. Oftentimes, we can help to assess the position of a line and report if it is sitting in an undesirable spot. This, on the other hand, is likely a side lobe artifact from the bright reflectors beside it. And here, we've got another example of reverberation artifact. Sitting between the left pulmonary artery and the descending aorta is a very bright reflection. This is an occlusion device for a patent duct. We will image this device to ensure it is seated in the correct position without any obstruction to the LPA or the aorta. We will also ensure that there are no residual shunts around the device. The last echo bright item I want to show you is in the subcostal view of the atrial septum. At the entrance of the inferior vena cava to the right atrium, we have a mobile but normal eustachian valve. It is important not to mistake this as part of the atrial septum. When we freeze this image to measure the PFO, ensure we know that the plane of the septum is here and not between the septum and the eustachian valve, because we do not want to mistake this as the atrial defect. Like in this baby who has a prominent eustachian valve, note the curvature of this atrial septum. Now, looking at the color flow, we need to be careful not to mistake this normal flow from the inferior vena cava and the true patent foramen ovale. And finally, the take-home messages of this lecture. Use all imaging tools available to us to optimize our echo studies. This will help us be accurate in our interpretation. We should include all images and measurements in this protocol for a complete assessment. Be aware of imaging pitfalls and to not report erroneous measurements obtained from images that are not clear enough to provide a reliable measurement. Imaging neonates and isolates can be very difficult, from oxygen needs to crying babies. It is important to recognize and state any study limitations. And finally, to recognize ultrasound artifacts and to interrogate anything suspicious. For more information on this topic, please go to the Neonatal Hemodynamics Research Center website. Under Clinical Practice Guidelines, there are many resources, including an excellent teaching manual by the neonatology team at the Rotunda Hospital in Ireland. Thank you for joining the Foundations of Echocardiography, part of the lecture series from the Neonatal Hemodynamics Research Center.
And I'll stop sharing my screen.
Thank you so much, Jackie, for that wonderful presentation. So we will kind of get going with the panelist session, the question and answer session. And before we do that, I do want to introduce one of our other panelists. Dr. Bonnie Gisani is a staff neonatologist at the Hospital for Sick Children in Toronto. He completed medical school and residency in general pediatrics in India, and he completed his DM training in neonatology at KEM Hospital in Mumbai, and clinical fellowships in both neonatal perinatal medicine and hemodynamics at the University of Toronto. Dr. Gisani's specific research interests include the use of acetaminophen for management of PDA and transcatheter device closure of PDA in preterm infants. He's going to join Jackie on the panel for this question and answer session. And I don't know if we can all get our videos on.
Thank you, Danielle, for the kind introduction. Thank you, Jackie, for the excellent talk. And we are most happy to have questions from the attendees.
Great. So let's get started with the Q&A. And we have a couple of questions from the audience that I will go ahead and ask. I think the first one would be how do you have any suggestions for optimizing imaging, or what specific images you would use in order to locate catheter placements for central lines?
So for central lines, I guess, first of all, it really depends on where the line is. If we're talking about, your IVC or your SVC line, the best images I would say would be for the IVC, I would say for the subcostal view, where we're looking at the long axis and we can see it track through and into the RA. For the SVC, the subcostal is a little bit more tough just because you're a little bit far into the imaging depth. So the high parasternal view, there's a view where it's pretty much a bicaval view of the SVC and IVC in the parasternal long axis. Where when you're tilted into the RV, you can slide over a little bit onto the right side of the heart, and then you'll be able to see the SVC in long axis, and that's usually a good location to be able to see the line there.
And so I guess following on top of that, do you believe that that's the best view to actually visualize the SVC as well, not just for line placement?
That is a good idea. Yeah. And if there's any other pulmonary vein issues as well, that's another great location. Like it's more like a right parasternal view of that SVC. The other location that I'm thinking as well is your suprasternal short axis. So from the long axis where your indicator's at 12 o'clock, if you rotate it to a 3 o'clock, then you'll end up having your innominate vein into the right-sided SVC. So I've seen thrombuses in that location as well. So I guess any of those would be good.
Perfect.
Yeah, I agree with Jackie and Daniel.
Fabulous. And I guess for both of you, what would you think, or what would you tell trainees that the optimal amount of liver that they should include in their subcostal views? We saw kind of several of those views that you sent that had some liver. So what would you think would be that optimal and why?
Bonnie, I don't know if you have a more specific thought about this. For me, as far as cardiac goes, I don't really look at the liver at all. Sometimes it's helpful as an acoustic window to help you look at the heart, but for as a sonographer, I look at it very rarely. So perhaps Bonnie would be a better one for this one.
I think the only subcostal view where the liver does occupy the almost 3/4 the upper half of the screen is while you are navigating the IVC entering into the right atrium. That's the only view where we try to open up the IVC to see how distensible it is and whether it's collapsing with respiration. But there is no real and objective way to say how much of the liver should occupy the screen. It is, as Jackie had said earlier, you should have to maximize your frame rate. You should increase the depth and let the liver occupy the upper half of the screen.
Okay. Moving on to another question from our audience about tissue Doppler imaging. So a couple of issues with that, and what maybe you could say, what are the advantages of using tissue Doppler versus color Doppler imaging? Why we might use both, and then where the sample volume should be to try to get a crisp Doppler tracing.
So the first part of the question was tissue Doppler versus color tissue Doppler?
Color Doppler.
Color Doppler versus like pulse wave Doppler? Is that what we're talking about?
Yeah.
Oh, okay. I'll probably leave that one for Bonnie because I'm not sure what the literature is on that. What I'll tackle is the where to put the sample gate so that you can get an optimal image. So for optimizing the tissue Doppler, the name of the game is to make sure you're as parallel as possible to your cursor. One thing that I find very common is if people are placing that sample volume into the atria. So let's say this is your ventricle right here, and this is your ventricular wall, and this is your atria. You are aiming to put your sample volume as the heart is contracting within that basal segment. If your sample gate is here, you can see that as the heart moves, it moves away from the central volume, and you're ultimately sampling the LA or the RA, depending on which wall you're talking about. So I think that making sure that you're deep enough into the ventricle without, let's say, going into the mid or obviously the apex area, then that's where you're going to be able to get your best sample.
Coming to the question, I think what Jackie had mentioned in her presentation, tissue Dopplers are used especially to measure IVCT, myocardial performance index, TAPC, SEA, SEA primes. I don't get the question as to that substituting color Doppler or 2D images. We are answering very specific pieces of information with tissue Doppler, and as Jackie said, those are the key areas where the sample volume should be.
Okay, perfect. And I think we're running a little short on time, so I'll get to one of the other questions from the audience. And you showed pictures of the arch, and you talked about, some of the artifacts that can make it look like the isthmus is actually small. But in babies who may actually have something like a hypoplastic arch or a coarctation, what is your approach? And I guess also from a T&E side, where perhaps it wouldn't be a cardiology sonographer doing the actual echo, how you look for it and ensure that it's not present?
Great question, thank you. So the images that I've shown of the arch really looked at, your ascending, transverse, and sort of the beginning of the isthmus area. That's a really typical view that you're going to get for a lot of the neonates because they don't have the acoustic window to be able to go any lower than that. One trick that I use is I just slide down a little bit. So from your suprasternal window, you're sliding down to somewhere in between that high parasternal and the suprasternal window, where you're looking at the duct. So your long axis of that arch ends up opening up a little bit because you're now skipping over those artifacts and you're able to see that lower segment. More often than not, I am taking multiple images so that I can ensure that I'm getting all of those pieces of the arch. It's lucky that we're always going to be doing a PDA sweep, because in that color sweep, you're going to be looking at that isthmus area. And if you have turbulent flow, then that's a big clue, of course, to doing further investigation. And then lastly, I would think the abdominal aorta Doppler. If you see any suspicious flows there, then that would be a clue, as well as your continuous wave and pulse wave Doppler of that descending aorta area in the suprasternal notch.
Bonnie, anything to add?
No, I completely second that.
Okay, so I think, oh, okay. Well, we have one other question. I had another question that I was going to ask, but a basic question from the audience of understanding how to do the RV3 chamber view, and probably just exactly maybe talking a little bit more about where to put the probe.
Yeah.
So the RV3 chamber is a little bit awkward because we don't have a very good a standard location like we do in the LV. In the LV, when you're putting your probe down, you're looking for the apex. You're looking for your apex to be pointy, if you would. Then you know that you're in the right spot. And as you rotate on top of that LV apex, you're going to have to stay on that point to be able to get your perfect 2 and 3 chambers. Whereas when you go onto the right side, you don't have a specific apex that is even to be able to rotate on top of. So the advice I would give is when you are in your LV2 chamber, stay in that spot and then just angle towards the RV or anteriorly from there. That is going to be your cut for your inflow and your outflow. And then if you don't see a good image there because the window's not there, then slide up slowly, incrementally, until you do get a better window. That would be my advice for that. Unfortunately, some kids don't have that because, again, if you're angling anterior, then you're fighting with lungs or whatever else. So you end up sliding so high that you're in the parasternal window. But that's the method that I would use. And then, sorry, I think that was it. Bonnie, any thoughts?
The key in RV3 chamber is, as Jackie said, angling anterior from the LV2 chamber, and to ensure that you are seeing your inflow, the tricuspid valve, and the outflow, right ventricular outflow tract. Both valves are clearly delineated, and there's no foreshortening of the RV apex, so that you can calculate RVFAC with both valves seen opening and closing at the almost in tandem to each other. If you angle too anteriorly, then you would see the middle portion opening up completely. But if you go too high up, you would have a foreshortened RV.
Great. Well, unfortunately, we've come to the end of the time for this session. I want to thank everybody for joining us, and a reminder that the recording will be available on the NHRC website for members. Thanks again to Jackie and to Bonnie for joining our panelist groups and answering all of these questions. And to Danny Weiss, of course, for being the co-chair and helping set up this lecture series. We look forward to seeing you every first Wednesday of the month at the same time.
Thank you, Daniel. Thank you, Jackie.
Thank you, everybody.
Thank you, everyone.